as many of you will realize, genetics has started to become important in cancer. Professor Gamella is the chairman of the Department of Urology and also the professor at Jefferson Medical College in Philadelphia, which, for better or worse, is the largest medical college in the United States. So probably about, 20% of all the doctors in America have gone through it at some point?
So there are more graduates of Jefferson Medical College practicing medicine in the United States than any other medical school. So I don't exactly know the percentage, but it's been around for almost 200 years.
So the other thing that Dr. Gamella has done was that in 1993, he was actually the first person ever to write a book about prostate cancer for patients. I hope he's learned a little bit since then. So with that, Lenny, please. Can we have Dr. Gamella's
slide? Thank you. Thank you, Mike. And really, this is probably the biggest congregation of patients I've seen on a Saturday morning. So kudos to all of you for coming out and participating in this program. And again, as Mike mentioned, everything's very informal here. And from my standpoint, when I talk about this first kind of heavy area of genomics and genomic testing, Tiffany Lewis and I, who is a specialist in genetic counseling, will have a breakout session so we can get maybe more into individual questions and discussions. But I'd like to thank the whole team here, the Prostate Cancer International, Mike Scott, Jan, our good colleague down here in the EVMS system, Dr. Paul Schellhammer, for this opportunity to come down here and to be with you today. So this is as Mike mentioned, a longstanding interest of mine. I think there's a boatload of information about prostate cancer, as you all know, out there. But to get really the essential information with somebody not really trying to sell you something or make you buy some special magic cure in a bottle. I think there's all sorts of information on the internet, but to get together with experts like you're going to have here for the opportunity to talk to today, I think will be a worthwhile activity. And again, it's a great honor to be here, and I'm very, very happy to participate. So what I'm going to try to do in the next couple of minutes is bring a lot of you back to college or possibly high school. And kind of give you an overview of this very heady area of genetic and genomic counseling for prostate cancer. So this is just a partial listing of the very famous people that have talked publicly about their battles with prostate cancer, be it from diagnosis or being from a treatment standpoint. And I always like to ask, particularly for the medical students, why is there a box of Frosted Flakes up there? So I'm sure that Mr. Scott will give somebody a free night at the Holiday Inn here if they can figure out why he is up there, but I will tell you who that is in a minute. But the reason I show you this is that prostate cancer is not one disease. Prostate cancer is a spectrum of diseases, how it affects each individual patient, and that's why I like to show this slide. So if you look at the celebrities here who've had their challenges with prostate cancer, everybody's different. Everybody has a different story, how they were diagnosed, how they were treated, and how some of them did. Some of them did very well, and unfortunately some at the bottom of the list did not do too well, and some very famous people have unfortunately passed away from prostate cancer. But the reason that the Tony the Tiger Frosted Flakes is up there is because of a gentleman by the name of Thurl Ravenscroft. Does anybody know who Thurl was? He was the voice of Tony the Tiger, the guy who does "It's Great." He did that voice for 50 years, and in fact, he battled with prostate cancer, and 2 weeks before he passed away from prostate cancer, he was still doing voiceovers for Tony the Tiger. So an incredible man with an incredible story about prostate cancer. But what's missing from this list is the next generation of information on prostate cancer and celebrities: genetic testing. No one has really talked about genetic testing. We've had people talk about PSA. We've had people talk about how they were treated and how they're how they're doing and how they're not doing or not doing as well. But we haven't had anyone really talk yet about genetic testing, and I think this is an important area. We're going to talk about one very famous person in a couple of minutes who talked about genetic testing a few years ago, and while she didn't talk about prostate cancer, she was really talking about prostate cancer, and we'll talk about that in a couple of minutes. So some of the things that this conference is going to cover, and that many of you are very familiar with: the prostate cancer issues and controversies, prostate cancer crisis due to an aging population. We know most men who are diagnosed with prostate cancer tend to be a little bit more senior. A lot of men have non-life-threatening prostate cancer which happens just as a course of aging, which will never harm a man in his entire lifetime, and that's where active surveillance becomes important. Cost is a big issue, and since the government, Medicare, the VA, other organizations pay a large percentage of health care for older Americans, this is a big concern. It's a large health care system. We unfortunately have no options for prevention. We thought we did a few years ago, and right now it doesn't look very promising that, at least in the short term, we're going to have a drug approved to prevent prostate cancer. We all know that screening is imperfect and also very controversial. For local disease, we have many, many, many options. A lot of them are traditional. A lot of them are technologically advanced thanks to new machines and equipment that we have. But unfortunately, we still deal with a lot of local side effects with prostate cancer, and as providers, we recognize that. Advanced disease, we had very little until 2010, and now we've had this explosion. 5, 6, 7 different agents, and a couple of more on the horizon, probably going to be approved in the next year or two. So now we have many, many different options, which is actually good because we can work our way through these different options if one doesn't work. Technology, rapidly expanding, but unfortunately expensive. And it goes back to the top issue, who's going to pay? And that's one of our challenges that we deal with. And lastly, this area of genetic testing. This is a really rapidly evolving area, and in fact, it's really only coming into its own over the last 2 or 3 years in prostate cancer. So we're at the earliest stages of really understanding what are the genetics, what is the inheritance risk of prostate cancer. And that's what we're going to be talking about in the next few minutes. So with the background to what I'm going to be talking to you all about, we know that about 5 to 15% of prostate cancers have some component of an inherited predisposition. Now, that doesn't mean that it is passed down from grandfather to father to son. It just means that there is some type of genetic alteration that we can identify in larger family units that predisposes a man to develop prostate cancer. Now, one thing I'm going to probably say 10 times, the genes that we're going to talk about today do not cause prostate cancer. And this is a very important point. However, if you develop prostate cancer, the genes that we're going to talk about are troubling. They're like accelerators in a fire. They seem to make the cancer behave in a different way. And that's an important concept I hope to leave you with today. Genetic counseling and testing may benefit the individual patient, but as we're going to see, as is the story with the breast and ovarian cancer in women, we're seeing the same pattern come up in men. So while we're here today talking about this, we're going to be talking about prostate cancer, but you're going to hear breast and ovarian cancer mentioned a lot, and you're going to see why in a couple of minutes. These genetic testings may help us with decision for cancer screening right now. We're not there yet. This is very important. In breast cancer, we are there. The genes that we're going to talk about, the BRCA1 or 2 gene, very important for breast and ovarian cancer screening. They appear to be starting to be equally important in prostate cancer, but we're not there yet for the BRCA1 or 2 gene to direct a man's screening. But I will tell you, probably in the next 3 to 5 years, that's going to come into our screening for prostate cancer. It's certainly entering our treatment for prostate cancer, but it's not yet entering our screening for prostate cancer. Again, very rapidly evolving area. So all over the place, you see genetics, genomics. You can't help but look at a newspaper article, a magazine cover, talking about genetics and genomics. This is the next wave of what we're doing in this area loosely known as precision medicine, where we're not treating patients with prostate cancer per se, but we're trying to drill down on the specific genetic alterations in a specific patient. be it for prostate cancer, breast cancer, lung cancer, or colon cancer. Down at the bottom there, I have a question mark with something that I sort of loosely call recreational genomics. And these are these things that you sort of see on TV, 23andMe and Ancestry.com. And they're kind of fun and things like that, and figuring out what your ancestry is. And maybe if you thought you came from Eastern Europe, in fact, you came from Southeast Asia and things like that. But there's a big problem with these. And the problem with these assays, these recreational genomics, is they are low cost. There's no question about it. But the accuracy is not there. The technology doesn't really ensure that the results you get from those recreational genomics are really validated. Now, the companies will argue with you. I guarantee you they'll argue with you. But at the end of the day, most of our legitimate medical tests that we get for genetics and genomic testing cost $2,000 or $3,000. They're expensive. But I'm going to tell you in a minute why they're not $69. There's a very specific reason. So these recreational genomics are out there. So they're low cost. And if they make a mistake, what's the big deal, right? Well, one of the problems is Neanderthal ancestry here. If Lydia has 293 Neanderthal ancestors and 23andMe made a mistake or Ancestry, does it really matter? No, not really, because it's fun recreational genomics. However, this is one of my pet peeves, and this is a scary thing to me. 23andMe today now will allow women to be screened for breast cancer genetic testing. How the FDA approved this personally was beyond me. I think this is personally a travesty. And again, this is just Leonard Gamella speaking. I don't speak for any organization. And why is that? The test only reports out 3 of more than 1,000 BRCA mutations. Is that really true? So some lady is going to go out there, get this 23andMe test and say, oh, I've got genetic screen for, I'm okay. Is that really correct? Is that really true when there's over 997 other genes that this assay doesn't test for? So this is a problem we have. This is what happens with commercialization and trying to get things out there. So not a big fan of this. So what are we talking about? The first part of the talk, I want you all to become like that commercial you stayed at a Holiday Inn Express last night. This is not a Holiday Inn Express, right? But you became an expert in an area. I hope to leave you all with basic information on this whole words that we use, genetic and genomic testing, so you can understand at least a little bit. It's a very complicated area, and again, there's years and years of PhDs that people get, but I'm going to try to give you the capsule summary that you can leave here and understand genomic and genetic testing. So, what does precision medicine have to do with this? I mentioned a couple of minutes ago that medicine today is going towards not just one treatment for one disease, but identifying your disease, the specific characteristics about your disease, and designing a treatment for you that is specific for you. This is the future of medicine. You see TV commercials right now for Keytruda, right? Have you all seen the Keytruda commercials where they talk about my ALK, I don't have an ALK alteration and I had an EGFR, and they give you all that technical information? What does that speak? That's double speak for precision medicine. They're telling you they looked at my tumor, it has this alteration but doesn't have this alteration, so guess what? This Keytruda treatment is right for me. That's what precision medicine is, and that's what we're going to be doing in the next 5 to 10 years, is really seeing this area explode. So, what is this all about? What is personalized medicine about? What is precision medicine all about? This is about your genome. Your genome is a fancy word for all of the DNA in your body, which is unique to you, in probably 1 in 10 million, 100 million people. It's your unique DNA. Almost no one has the identical DNA to anybody else. Even relatives, even identical twins may not have the same DNA because of changes that happen. But this is what forensic medicine is all about. This is how you're able to identify people, because your DNA is so unique to you. If you're a crime scene investigator or you watch CSI and all that other stuff on TV, that's how this is able to work. It's able to identify individuals based on their genome, which is basically a big word for your DNA in your cell. So here it is. Welcome to the genome, and I'll read this paragraph. The miraculous blueprint of your DNA, coiled as tight as a spring in the nucleus of each cell of your body, And if unwound, the DNA from one cell, while only a molecule in width, would stretch almost 6 feet in length. And this information is stored in something known as a double helix, which is over 3.2 billion bits of information. And if you can take this into a phone book and run it in an alphabet, ATGC, whatever, it would fill 142 Manhattan phone books. The reason we talk about this is this underlies the complexity of what we are trying to do today in medicine into identifying your unique characteristics and unique way to treat your cancer. So on the right-hand side there, you see that coiled DNA that's in every cell in our body. And what it does is it winds itself up into individual chromosomes. Those individual chromosomes live in the nucleus of every cell in our body, and the nucleus in our cell is the master control center. It tells that cell what it is going to do. So your genome, all the instructions on how your body is going to work, how you're going to grow, how old you're going to live, how you're going to develop different diseases, your eye color or your sight. And when you inherit this, half of it comes from your mother and half of it comes from your father. And this is very important when you start to get involved with genetic counseling and genetic screening to understand your genome doesn't come from, even though you might look like your father, or you might look like your mother, in fact, you're half and half. You get half of this from one side of the family and half of this from the other side of the family. So, these genes, this genome, does not live in isolation. It doesn't function in isolation. What we're learning is the fact that these genes can be affected by other things in the cell. Stress, lifestyle, cigarette smoking, sunlight exposure, the environment. So this is very complicated. So we're trying to understand the genes in each person, but we also recognize there's stuff going on in the environment, stuff going on in people's lifestyle, exposures to toxins, different activities, a lot of exercise, a little bit of exercise, and the like. So it's not as simple as we think it is. So you start with your genome and your genetics, and then you can maybe alter it. Anybody know what curling is? Anybody know? So it's sort of like curling. You're sending the stone that way, but if you rub the brush on the ice, you may move it a little bit in one direction or the other, but guess what? You're going in that direction regardless, and that's really where the environment becomes very important. So why is this all happening? Why was this quiet for years and years and years, and now you're hearing all about genomics and genetics? Well, it's thanks to our government. In 1990, the government the NIH started something known as the Human Genome Project. And the goal was to map the entire human genome. Now remember, this mapping process is not simple. This is numbers or letters in a phone book, 142 Manhattan telephone books worth. Took a long time. In the early 1990s, when you went in there and you tried to figure out this letter sequence, you can only do it in short little bits, maybe 50 or 100 letters at a time. As time went on, the technology and this thing that you may hear these words used, next generation sequencing or deep sequencing, it means that you're able to do, through computer technology, investigation of these letters, but you can do more and more letters at a time, but more importantly, do it more rapidly. So the progress was really slow in the first 5 or 10 years of this project, but it took them 13 years. And why did it take so long? There are 3.2 billion base pairs. Those base pairs are the things that make up the two sides of that double helix of the DNA, and that's why it took so long. So the government finished this project in 2003. What happened after that was, since this was published, all these companies started to get involved with genomics and genetics. And they started to explore different ways of bringing this to healthcare and figuring out individual processes that will help a patient with their healthcare. Now, a few more little terms. Genetics. The very traditional word of genetics is what you inherit from your parents. We've known about that. Those of you that may remember back to high school, Mendelian genetics. The monk that looked at different peas and figured out the different peas and the sizes of the peas. We were that way for hundreds of years. Now we're moving towards the fact that we can actually identify the pieces in the cell that contribute to that genetic inheritance of diseases in particular, or your eye color or your height. So traditionally, we would find one gene would be responsible for a disease such as Down syndrome, or one gene would be responsible for a condition known as cystic fibrosis. Well, as modern technology has gone forward, we realize most diseases, be they cancer or non-cancer, are more complex than that. It's probably a bunch of genes that are interacting with each other in some sort of a witch's brew to make something bad happen in the individual cell. So you all know the word already, genome is your DNA in the entire cell that you have. However, the word today, genomics, really refers to this more complex area, the fact that we're talking about not just one gene, one abnormal area in that DNA, but we're talking about a whole bunch of them and figuring out how they interact with each other. So today when you use genetic testing and genomic testing, they're almost the similar terms. So a little more basics, a little more schoolwork before we get into the details about prostate cancer. So the genome is your whole DNA set. The DNA is made up of these base pairs that we talked about that couple up different molecules with each other. So there's AT, GC, GA that run down that whole 6-foot-long piece of unwound DNA. To get an idea, a bacteria has 600,000 base pairs, but humans have 3 billion base pairs. We're obviously much more complicated organisms. In our body, every cell has DNA in it, except for red blood cells. Red blood cells do not have DNA, and white blood cells do, but the red blood cells don't. These DNA units are broken into chromosomes. The chromosomes live in the nucleus, and again, that's the command center inside of the cell. But here's a very interesting thing at the bottom. What do these things do? We've talked about the genes, but what do they actually do? The genes make us who we are. Genes make proteins. Genes make about 30,000 or 40,000 different proteins that make us a human being, whether it's our skin, our hair, our eye, our retina, our stomach, our skin. But what's really interesting is we're at the next frontier. If you look inside a cell, we only know what 2% of those genes that DNA does. And that's the 2% we know about. 98% of what's in that genome, that DNA, we have no idea what it does. It's there for a reason. And you're going to see the next years an explosion in understanding. We got the genes we got figured out, but we got this whole 98% of what's going on there. We have no idea. And that's how medical science is going to be advancing in the next couple of years. So this is sort of a general idea about how we talk about a tumor. And we're going to be talking about prostate cancer. So I didn't show a prostate here. This is actually a kidney. But we got CAT scans that show us lumps. We got the actual tumor. We look at it under the microscope, and the pathologist tells us what it is. And sometimes they look at the cell, and sometimes they take a look at the nucleus. But that's the way 99% of diseases, cancers like prostate cancer, are diagnosed. The pathologist looks at the microscope, looks at the cells, and makes a determination. As we get more detailed and get more information, we get into something called karyotypes, where you actually start to look at the individual chromosomes and to see, are they altered? For example, Down syndrome, trisomy 21, you see an actual change in that chromosome. But now we're beyond that. That's yesterday's technology. That's from the last century, karyotyping, looking at that whole chromosome. Where are we today in precision medicine and genomics? We're now looking at what you cannot see under the microscope. You cannot see these base pairs. This is what we're talking about. This is incredible amounts of information. Remember, the human being has 3.2 billion of these alphabet soups in the normal cell. So again, the human genome we talked about in human beings. Again, I don't know if these would stack up as high as the Washington Monument, but it's a nice little graphic to look at. So you've got all these phone books here for the human genome. These guys say 200 phone books in this website. But again, relatively speaking, look at a bacteria. A bacteria would be 300 pages of the phone book. So the complexity of the human genome is enormous that we're dealing with. And hence, why does things take so long? Because it's so complex. We cannot do this without computers. You know, what was that, 2021, the Space Odyssey, whatever, where the computers ran it? We're completely dependent on computers. I mean, well, we all know every day with our cell phone, which is completely driven by computers. Well, what's happening now? Medicine, genomics, relies on computers. It is humanly impossible to figure all this out, to figure out what's going on without computers. This is just one area of a gene that we're going to talk about, the BRCA2 gene. And this is one area, 12 pages long. This is what we're looking at when we talk about a gene. And all you're trying to identify is a switch here between a CA and an AG or an AT. It's that subtle. And suddenly you've got this BRCA1 or this BRCA2 abnormality that messes up your cell and causes it to, or encourages it to become cancerous. This is the problem when you look at 23andMe, when they're only telling you about 2 or 3 genes. Well, there's 1,000 different BRCA abnormalities. Some of them may be a change over here. Some of them may be change over here. So this is a challenge that we're facing. So just the last little bit about this before we dive into prostate cancer. Most of what we do today for genetic testing involves just a buccal swab. And how many people have done a 23andMe or an Ancestry? I won't ask about your Neanderthal relatives, so you're safe in that regard. So this is all you do. It's just a buccal swab. And what is that doing? That's just scraping some cells off the inside of your cheek. The same DNA that's inside your cheek is in your big toe, it's in your brain, it's in your nose, it's in your colon, it's all over the body. So that's what genetic testing is. On the other side, genomic tissue testing, and you have Foundation Medicine out here, which is a good example. What that is that's a different type of genomic testing. We're not going to be talking too much about that today because that's not what the job of our talk is today. But it's another type of genomic testing where you actually look at what's going inside of somebody's tumor and the crazy things that happen to make a cell cancerous. That's what you're doing with assays like Foundation Medicine and others, where you're actually looking at the tissue. And what you're doing is a genomic analysis of the tumor. What we're going to be talking about today is a genomic analysis of what you inherited from your mother and father that may or may not be inside that specific tumor. I use this term deep sequencing. This stuff has come down in cost and time, down to only a couple of $1,000s. And why is it? This is because of this gene chip. This is this little chip that they can plug into a very complicated and sophisticated computer and print out your sequence. But the sequence doesn't get printed out. The computer looks at everything and says, oh, this is a BRCA1 or 2 abnormality, or this is a RB abnormality, or an EGFR, or an ALK abnormality. So the computer takes all this information and presents us with a very clear picture of what that gene is, what's the abnormality, and maybe we have a way to treat it based on that abnormal gene. Okay, this is one of the money slides that I'd like you guys to remember when you think about genetics and genomic testing. So we mentioned earlier germline mutations. This is the hot buzzword right now. Germline, that refers to what you inherit from your mother and your father. That is in every cell in your body. Somatic mutations are the crazy things, the wild west of a tumor that starts to grow, that does anything it wants to do. It doesn't necessarily follow the germline. It starts to mess up every gene in there, because remember, cancer is a genetic disease. It's caused, that doesn't mean that it's inherited in everybody, but it's caused by messed up genes. Remember, the nucleus is the controller of the cell. The DNA lives in there. And all the signals start with DNA making the proteins. Well, if something gets messed up in the cell, that's when it turns cancerous. So that's what we're talking about with these alterations inside the cell. But remember, a lot of them are not necessarily inherited. Some of them, they're just the crazy things. And in fact, as we'll talk about, 80%, 70% probably of prostate cancer is sporadic. What does that mean? We can't really trace anything. It's just something that happens in that tissue that we're trying to figure out to make that cancer cell become cancerous. So now let's get into the nitty-gritty about prostate cancer. Something very big happened in 2013, and in fact, two big things happened in 2013. The first thing was Angelina Jolie. What does Angelina Jolie have to do with prostate cancer? Angelina Jolie probably single-handedly brought the world the concept of genetically inherited cancer. And the words BRCA1 or 2 were associated with Angelina Jolie. Why is that? Because BRCA1 or 2, if you have alterations in those genes, predisposes you to breast and ovarian cancer. Her family had a very strong history of that. She underwent the genetic testing. They saw that these BRCA1 or 2 genes were altered in her. They were mutated. She elected to have a prophylactic oophorectomy and bilateral mastectomy. I can guarantee you before 2013, if you polled 100 people on what a BRCA1 or 2 was, nobody would know what it was. So Angelina Jolie really brought this to the world to understand we have identified some inherited genes that, again, I want to say this one more time, these genes don't cause cancer, but they seem to be accelerants. If you develop a cancer, they seem to make the cancer worse, or they predispose you to cancer. We still don't know the trigger for a lot of these cancers that we're going to be talking about. The other important thing that happened in 2013 was the fact that a company known as Myriad, who had patented something known as the BRCA1 and the BRCA2 gene. That was BRCA1 or BRCA2. They patented that gene back in the mid-1990s. And the Supreme Court said to these guys, you can't patent a naturally occurring gene. That's not allowed. What did that mean? That meant that all of a sudden now there was an explosion of companies out there that were able to offer genetic testing for BRCA1 and BRCA2 genes, again, primarily involved at the time and still today with prostate cancer. So now let's do a little bit deeper dive into prostate cancer with that background. Because again, I don't think talking about this without that background, it makes a lot of sense. So with the strong background that we talked about, we recognize that all cancer is genetic, but not all cancer is inherited. So we talk about the genetic changes that happen in a cell that cause it to stop obeying the rules. It's like a renegade. The nucleus gets some changes in it, altered genes, the cell starts growing, it doesn't follow any rules of the road. And of course, you end up with malignant tumor growth. So when we talk about inherited cancers, we talk about three types of we talk about cancer susceptibility: sporadic, familial, and hereditary. Sporadic are just cancers that happen. We don't exactly know. There's no genetic predisposition. And in prostate cancer, that's the majority today. So not everybody has a truly inherited prostate cancer. Most of them are sporadic. Some prostate cancers are due to familial clustering. In other words, there's maybe somebody with a related cancer, and as we're going to talk about, ovarian cancer, maybe melanoma, maybe pancreatic cancer. There's something in the family that has been inherited that increases the potential for developing these different cancers. The last one, hereditary cancers, we have some in prostate cancer. They're very rare, but there is a gene known as the HOXB13 gene that if a family has that HOXB13 mutated gene, men tend to develop prostate cancer high grade, younger than the age of 55. So right now, that is the only truly inherited prostate cancer gene that we have, where you can trace it in the grandparents, you can see it in the father, and you might see it in some of the children, the boys and their brothers. But that's very rare. But obviously, if you're in that family cluster, it's very important to know that this is an inherited gene that really is known to be very highly associated with prostate cancer. The reality is, again, most cancers, prostate cancer, are sporadic, but some of them are familial. And to be honest, that's what we're going to really be focusing on, the familial cancer. things in families that tend to run. Now, we all know that somebody's got a lung cancer, somebody's got a colon cancer, somebody has a brain cancer. Some of those we haven't been able to connect the dots yet. But as you're going to see in a couple of minutes, we're going to be able to connect the dots of some cancers that run in families. This area is so confusing and so rapidly evolving. About a year and a half ago at Jefferson, we did something that was never done before. We actually got a bunch of urologists, radiation oncologists, medical oncologists, patient advocates, genetic counselors, bioethicists, patients advocates, and we spent 2 days coming together trying to sort out this new information to try to give both providers and patients guidance on what's the deal about inherited prostate cancer risk. Does a man really need to worry about it? Does a mother need to worry about her son when the father passes away from prostate cancer? So we published a big paper a year ago that focused on a lot of these areas. And I don't want to get too much into the paper, but I want to show you the high-level things that we addressed a year and a half ago that are now being accepted in the United States and other parts of the world about this area. So we looked at which men should consider genetic counseling and genetic testing for prostate cancer. We looked at which genes should be tested. And we also looked at what genes should be factored in different areas of the treatment continuum, for example, from screening, early prostate cancer, advanced prostate cancer, and then metastatic castrate-resistant prostate cancer. And again, I'm not going to get into all the details that are there, but the concept was this was the first time some general organization came into this whole area. We got this, I don't want to say we have this knocked in breast and ovarian cancer, but this has been well described. These genetic tests for breast and ovarian cancer have been known about since the early 1990s. You might hear about something known as the Ashkenazi Jewish population. There is a group of individuals from Eastern Europe who are Ashkenazi Jewish descent that these BRCA1 or 2 genes called founder genes were first identified because of the extraordinarily high prevalence of breast and ovarian cancer in that ethnic group. That's how that gene was first described. The BRCA1 or 2 genes were described in the early 1990s. So what I want to show you here is just a partial list. These are the genes. Gene known as ATM, BRCA1, BRCA2, CHEK2, and so on. These are the common genes that we have now identified that increases a man's risk of developing not only prostate cancer, but aggressive prostate cancer. And again, we haven't got this all figured out yet, but we know that these are bad genes. If you got these genes and you get prostate cancer, the outcome, we're concerned about the outcome. You may end up having a more aggressive prostate cancer. And then the big question is, why do this genetic and genomic testing? Because it, number one, may help you be screened for other cancers, as we're going to talk about. We now know that these BRCA1 or 2s are not isolated to breast cancer and prostate cancer, but they're also pancreatic cancer, melanoma, some colon cancers as well. Now, the relative numbers are small, but if it's you, it's important. So, what about BRCA1 or 2? We've mentioned that repeatedly. What's the deal with this BRCA1 or 2? And again, there's many other genes out there, but I want to focus on the BRCA1 or 2 because that's the one we know the most about. That's the Angelina Jolie gene. We know it in breast and ovarian cancer very well, and we're trying to figure it out in prostate cancer. But what we have discovered over the last couple of years are the following. Remember, these genes don't cause cancer. Please remember that. But they make the cancer more aggressive. They do something. So we believe it's kind of important to know if many men with these gene alterations have prostate cancer, should we be doing something different? And again, I don't have the answers today, but I'm letting you guys, and you guys can be the lead on this, and when you have conversations with people, we're trying to figure this out. But we know they're important. Why? 2 to 6 times increased lifetime risk of developing prostate cancer in a man who has a BRCA1 or 2 abnormality. Almost 9 times risk of at age 65 of being diagnosed with prostate cancer. But here's the big thing that I, as a urologic surgeon and a cancer doctor, worry about. these cancers are more likely to be aggressive. Not only do they increase your risk of developing prostate cancer, but here's the big concern. It's going to be a more aggressive cancer. I know you all are very familiar with Gleason scores and things like that. It's going to be a Gleason 8 or likely to be a Gleason 8 or higher cancer, more likely to be metastatic and more likely to be outside the prostate. But here's the shocker that has come out over the last 2 or 3 years. Not only do the BRCA1 or 2 genes impact breast and prostate cancer, there are other cancers that run in families that are probably associated with this BRCA1 or 2. Breast, ovarian, melanoma, pancreatic, Lynch syndrome, colorectal, and gastric cancers. So I will tell you a shocker. There was a dear patient who last year was his 10th or 11th year that I had taken his prostate out for prostate cancer, and he did fine. The reason he had his prostate cancer detected was his brother had his prostate cancer detected. They both had aggressive disease. His brother was treated elsewhere, and I treated Tom. This is the shocking thing to me. About 2 weeks after the consensus, Tom picks up the phone and calls him and goes, "Lenny, I got sort of bad news for you." And I said, "Oh my God, what's going on?" He goes, "I have pancreatic cancer, and they don't give me long to live." And I go, it was like a shock to me because I didn't really know that pancreatic cancer and prostate cancer were connected. And then he goes on to tell me, "You remember my brother John?" I said, "Yeah, very well." He goes, "He died of pancreatic cancer about 6 years ago. We both had prostate cancer. We both had pancreatic cancer. What's going on?" And this is 2 weeks after the symposium where I learned for the first time there's a connection. So the bottom line is that these tests are not only for the individual, but maybe the family. Maybe we can learn something to screen other members of the family earlier. And again, as I mentioned, the BRCA mutation, if one of your parents has that, the children have a 50% chance of having that mutation. So this is this concept of not only the individual, but the heredity, that these altered genes in the germline can be passed down from generation to generation. Now, the impact of BRCA1 or 2 of breast cancer is well known and much greater than the impact on prostate cancer. So I don't want anybody leaving here today thinking that BRCA1 or 2 has got the same impact as it does for breast and ovarian cancer. But it is real. And remember, there's about 700 men a year in this country who develop breast cancer. Men get breast cancer, male breast cancer. So these families that have a BRCA1 or 2 abnormality, why is it important to know that? That man should be vigilant for breast cancer. You might want to be more vigilant for melanoma. Pancreatic cancer is a little bit tricky because that's a cancer very difficult to diagnose early. But again, this may increase vigilance. If you know you have this gene, you may want to be screened a little more closely for certain common cancers. But again, that's an individual discussion to have with the doctor. But if you look at these BRCA1 or 2 abnormalities, and again, I'm just focusing on BRCA1 or 2 as sort of archetypical genes that we see more commonly than other genes in breast, ovarian, and prostate cancer. But you see for women, the impact is much, much higher than in men. The numbers are relatively low for men. In particular, 25% BRCA2 in this particular study. So the impact is far greater in women, but we're learning there's an impact in men. So there are hereditary cancers in the family that can be associated with this BRCA2. And remember, since these germline altered genes are passed down through generations, we talked about male breast cancer, melanoma, colon cancer risk, stomach cancer risk, and others. So these hereditary syndromes may be in the individual, but they may also be involved in other members of the family. So putting this all together, what should we be doing right now? Well, one of the things that we came out of our consensus meeting is using genetic counselors. And we're going to be talking with Tiffany in a couple of minutes at the next breakout session about how do genetic counselors work with patients, understanding genetic testing. Now remember, not everybody needs genetic testing. It's up to the genetic counselor to look at your family history and look at your tumor characteristics and decide, should you have genetic testing? But here are some of the triggers that we're starting to look at in urology. If you've got many men, more than 2 men in your family diagnosed early than age 55, you should think about it. FDRs are first-degree relatives. Father, son, children, grandchildren. Those are first-degree relatives, brothers and sisters. But obviously, some sisters don't have prostate cancer. But if you've got a first-degree relative, again, in that immediate cluster, a parent, child, a brother, you should think about it. There's more than 3 individuals. And if you have aggressive prostate cancer with a couple of ladies in the family with ovarian and breast cancer, and I'll tell you, as a urologist, it's only been over the last 2 or 3 years. For years, we ask everybody, anybody in your family have prostate cancer? Anybody in your family have prostate cancer? Now we ask about other cancers. We ask about breast and ovarian cancer because we now know that tends to run in families. So it's completely changed how we do our intake history and physical when we see a man, either for screening for prostate cancer or with newly diagnosed prostate cancer. So lastly, the genetic counselors and genetic testing are very important in this. I'm primarily a surgeon, but we need genetic counselors and genetic advisors who focus on this area to help us understand this field. And that's why I think it's very important, if you're worried about this, you talk to your provider and you sit down with let him or her refer you to a genetic counselor to talk about your family history if you're concerned about it. And let them decide, should you have BRCA1 or 2 testing? Now, quick show of hands. How many men in this room have had BRCA1 or 2 testing? Very interesting. We have about 8 or 9. So if I would have asked this question 2 years ago, I don't think anybody would have put their hand up. So this is becoming something which is getting into the treatment continuum of prostate cancer. So genetic counselors look at family history, the cancer, other risk factors, and they look at you as an individual. Is this a hereditary thing or is this sporadic? And then they give you advice. A genetic counselor is a healthcare professional that knows a lot about clinical genetics. These people have advanced training. We don't have enough of them, but we need to be partnering with them more and more in all aspects of medicine as precision medicine and genomics and genetics moves forward. So genetic counselors talk to you not only about you, but about your family. And I have to tell you something, this is a very tricky slope that you have to get involved with. There's something known as cascade testing. And I compare genetic testing to a bullet in the gun and a hand grenade. The bullet in the gun is you. It's just you. It impacts you. But genetic testing is also like a hand grenade because it might impact other individuals. It might impact your children. It might impact your brothers or your sisters. So go cautiously. Make sure you talk to a genetic counselor and realize that when you open this Pandora's box about looking at inherited abnormalities like BRCA1 or 2, it may not just be about you. There may be other members of your family who want to do this and other members of your family who have no interest in doing this whatsoever. So at Jefferson, we founded a multidisciplinary genetics clinic. We work with patients and genetic counselors. And I will tell you, at least half the men have no reason to undergo genetic testing because they don't have any sign of any hereditary or familial inherited prostate cancer risk. But what are the red flags? Early cancers, we talked about it. Cancer-impaired organs, and this is in the family now. When we say paired organs, we're talking about ovarian cancer, breast cancer, and things like that. Patients who have rare tumors. Patients who have multiple relatives in the family. Again, this is red flags for that. There may be something going on in the family, and this is beyond prostate cancer. This is talking about other cancers. So genetic testing, we recommend, as we talked about earlier, I'll sort of skip over this. 2 last concepts. Insurance, big problem. Medicare is actually quite good if you've got a personal and family history that suggests this might be hereditary cancer. Medicare is very good. Once you get beyond Medicare, all of the carriers have different rules about who pays for genetic testing and counseling. And remember, this is like I guess Forrest Gump said, peas and carrots. Okay, the genetic testing and the genetic counseling need to go together. You can't view one in isolation. It's not like ordering a blood test for anemia. You got to connect the blood test with the counselor. And lastly, GINA. Does anybody know what GINA is? Anybody ever heard of GINA? How about the guys who had BRCA 1 or 2 testing? Do you guys know what GINA is? Any of you? Okay, GINA is the Genetic Information and Non-Discrimination Act. Very important. We need to understand this. Why is that? The government passed in 2009 GINA to protect people who undergo genetic testing for inherited prostate, for inherited risk of any cancer. However, be careful. This is not completely protective. This protects you in employment. You can't be discriminated because you've got a BRCA 1 or 2 abnormality. You can't be discriminated in employment. You can't be discriminated from healthcare insurance. However, life insurance and long-term disability insurance, you can be held accountable and not get life insurance or long-term disability. So this is a problem. This GINA Act went so far, but it didn't go far enough. So people, remember, you're not completely protected by this GINA Act. And this is something genetic counselors are well aware of, but that maybe a lot of providers are not aware of. So where are we right now? These are rapidly evolving recommendations for genetic testing. Those are the most critical genes today. We talked about several of those. We're not there yet, but soon genetic testing is going to guide prostate cancer screening. We're not really there yet, but the issue of screening other members of the family is becoming important, particularly if you have those risk characteristics that we talked about for the inherited genetic testing. We really need more genetic counselors. This is a tremendous growth area, and if any of your undecided children or grandchildren don't know a growth field to go into, it's a great thing to go into because there's going to be a big shortage of these. There's already a shortage now, but there's going to be even a growing shortage well outside of prostate cancer. And lastly, we didn't get into this because it's beyond our ability to do this, but we have genetic testing panels that are being made commercially available. So lastly, Thanksgiving is coming up. You're probably going to want to get some fun genetic testing and things like that, but I'm going to save you a lot of money. When you're sitting around the Thanksgiving table, you don't have to worry about sending away for a $69 or $79 test. If you want to know what your ethnicity is or where your family came from, all you have to do is have all your relatives take their shoes off and look at the toe configuration, and that will help you decide, without a fancy genetic test, where your family's actually from. So, again, I thank you all for your thanks for your attention.
Thank you, Lenny. So we're going to be running another workshop immediately after this that deals very specifically with genetic counseling and genetic testing. I think if you've got questions, that's the best place to take those questions, given the time that we have now. And there will also be a genetic counselor there, as well as Professor Gamella, to deal with all of those. So thank you for your interest at this first session. We hope it's been educational for you, and we hope you enjoy the rest of the day.